Welcome to Integrated Medicine Perspective. I'm Dr. Wenli Liu. Though there has been increasing interest in antioxidant supplements, oncologists, cancer specialists, however, are not quite as enthusiastic about them. So today we're going to talk about why oncologists do not recommend antioxidant supplements. We know oxidative stress can trigger cell damage. It plays a role in aging and development of many diseases, including cancer, Parkinson's disease, and Alzheimer's disease, etc. Cell studies and animal studies have shown that antioxidants can counteract oxidative stress and inhibit cancer growth. So it all sounds reasonable to take antioxidant supplement. Then why oncologists hold different opinions? In medical research, regardless how reasonable or logical the hypotheses are at the beginning, getting completely unexpected opposite results is not uncommon. So today we're going to talk about two large randomized clinical trials using antioxidant to help prevent cancer. The first trial was in Finland using beta carotene and vitamin E to help prevent lung cancer. The participants were over 29,000 male smokers. After 5 to 8 years of observation, the participants who took beta carotene versus those who did not had 18% higher risk of lung cancer and 8% higher risk of death. The study did not find specific effect of vitamin E on lung cancer risks, but the participants who took vitamin E versus those who did not had increased incidence of hemorrhagic strokes, the bleeding type of stroke. The second randomized trial was in America using a combination of beta carotene and vitamin A to help prevent lung cancer and cardiovascular diseases. The participants were over 18,000 smokers, as well as people with occupational exposure to asbestos. After 4 years of observation, the study was terminated 21 months ahead of schedule. Why that earlier ahead of the schedule? Because the intervention group, the group took beta carotene and vitamin A, had 28% increased risk of lung cancer, 46% increased risk of death from lung cancer, and 26% increased risk of death from cardiovascular diseases. Now, the hypothesis of these two large trials were based on epidemiological findings. Vegetable intake and dietary beta carotene intake were inversely related to cancer risks, including lung cancer risks. So how do we explain the opposite result of these two clinical trials? What can we learn from these two trials? There are definitely several lessons that we can learn. One is that in those epidemiological studies, the measurements were vegetable intake, dietary beta carotene intake, blood levels of beta carotene. Now, dietary beta carotene intake and blood levels of beta carotene may be just the surrogate markers of dietary vegetable intake. So the relationship between dietary beta carotene intake or blood levels of beta carotene with cancer were truly the relationship between vegetable intake and cancer. Beta carotene may accurately reflect the vegetable intake, but it cannot accurately represent the entirety of the biochemical impact of intact vegetables or a combination of various intact vegetables. We cannot assume that beta carotene was the key factor of the underlying mechanism of vegetables' prevention of cancer. Interestingly, the Nature journal editor at that time put a couple of words at the bottom of the first page of the publication, warning readers to be careful about the proper interpretation of the epidemiological evidence, warning people not to automatically think beta carotene could prevent cancer. I think the editor's warning was relevant 40 years ago and is still relevant nowadays. The second lesson we could learn probably is the dose of beta carotene. The beta carotene dose in both trials was very large. The American trial used the beta carotene dose that was 17 times of the daily recommended allowance. The Finnish study was 11 times of the RDA. Blood beta carotene levels were also measured in the American trial. The blood carotene levels of the intervention group, the group took beta carotene and vitamin A, were 12 times their baseline, as well as the average levels of the control group. Now, their baseline level and the levels of the control group were normal levels. 12 times of that level could be toxic. In addition, when the blood level of one specific nutrient, in this case beta carotene, is significantly elevated, it may disrupt the appropriate balance between beta carotene and other nutrients. And the appropriate balance between nutrients may be very important to the cellular biochemical activities, including beta carotene's antioxidative activities. In any given chemical reactions, the molecular ratio of the involved elements is fixed. Significantly increasing one of the elements may not increase the final product. Of course, these large two trials are only part of the reason that oncologists do not recommend antioxidant supplements. I will, in the future, continue to share study results and epidemiological evidence about vitamin and antioxidant use in cancer prevention as well as during cancer treatments. Clinical trials, especially randomized clinical trials of dietary patterns or dietary elements, are not easy to do. We often have to apply epidemiological evidence to our clinical practice as well as modifications of lifestyle strategies. Just as warned and suggested by the Nature journal editor, we need to be very careful when interpreting epidemiological evidence. That's all for today. Thanks for watching, and I will see you soon.